linking research questions with implementation projects, the logical curriculum in public health by Professor B.R. Shamanna. Professor B.R. Shamanna is working as a professor at the School of Medical Sciences at University of Hyderabad. I am very fortunate to work with Sir when he is the faculty at our Indian Institute of Public Health, Hyderabad. Right. Previously, he served as a senior research officer in the International Council for Control of Iodine Deficiency Disorders. Professor Shamanna has been closely associated with the development and implementation of activities of two large WHO collaborating centers for prevention of blindness in India, first with Lions Arvind Institute of Community Ophthalmology of Arvind Eye Care System in Madurai, and with International Center for Advancement of Rural Eye Care of the L.V. Prasad Institute, Hyderabad. He is the visiting faculty to the Masters in Public Health Eye Care at London School of Hygiene and Tropical Medicine since 2002 and an adjunct faculty with the Public Health Foundation of India. That's why he is here to deliver this lecture on this third Friday. Professor B.R. Shamanna completed his medical education from Karnataka Medical College, Hubli, and community medicine from All Institute of Medical Sciences. He holds a diploma of National Board in Maternal and Child Health as well as Social and Preventive Medicine. He completed his MSc from the University College of London with distinction in Community Eye Health, and more recently, he secured a postgraduate diploma in medical law and ethics from the National Law School of India University, Bangalore, India. He has traveled and published extensively and has been widely acclaimed as an immensely motivational teacher. He is a very good teacher. His interest and passion is to cement the connection of health and development, and he believes in growing by helping others grow. His interests are health and welfare economics, disability inclusive development, education and teaching methods, implementation research in health sciences, and alternative options and policies in healthcare. With these few words about the speaker, I request our director, Professor G.V.S. Murthy, to address the audience on this occasion. Over to you, Professor Murthy, sir.
Thank you, Dr. Jairam. Namaskar to all the participants listening in, waiting to listen to Dr. Sham. But I'll just give a very brief interlude before we have the man speaking. So this is from the IIPH Hyderabad is the second lecture in the series of public health lectures, which has been initiated across all the academic campuses of the Public Health Foundation of India. What we have tried to do from Hyderabad is to try and look at sessions which can have a sharing of practical experiences so that one can use them in their own public health practice areas. And in addition to COVID, we are looking at the basic issue of why and how we can relate the question and then looking at the logical continuum of finding the answers and the implementation. The IIPH Hyderabad, as many of you are aware, is one of the academic institutions under the Public Health Foundation of India umbrella. The Hyderabad campus, which serves as the southern regional hub of the PHFI, was initiated, the initial MOU was signed with the Chief Minister of the then undivided Andhra Pradesh, the late Dr. Y.S. Rajshekhar Reddy Garu. and we are slowly moving into a place where we are going to move into a physical space which would follow up on the legacy which was set up by the late Chief Minister of the undivided state. We have an additional advantage at Hyderabad with which Dr. Shamanna is very closely associated, and that is to establish a center of excellence for disability inclusive development, which is unique across South Asia and mirrors the sort of work that happens from the International Center for Evidence and Disability at the London School of Hygiene and Tropical Medicine. So we are trying to replicate and mirror a lot of the activities which were initiated in relation to disability at the London School, and trying to see that the South Asia region can actually benefit from that. The reason why I'm mentioning that very important today is because Dr. Shamanna is one of the persons who was instrumental in making that happen and facilitating the process of setting up the center. And together, we have done a lot of work in relation to disability, inclusive development, healthcare access to people with disability. Though he's not speaking on that particular aspect today, the stamp that Dr. Sham puts in on public health automatically translates into public health disability also. So it is a great opportunity, Dr. Sham, to listen to you once again. You've been a star both on the cricket field, where you would have been perhaps one of the empowering panel members instead of teaching at the university. We missed that, but let's make do with your academic pursuits and look at the University of Hyderabad contributing to the improvement in public health in India as well as the other parts of the world. So it's an honor and privilege, along with you, to also acknowledge the presence of Dr. Rajan Shukla and Dr. Nanda Kishore. Dr. Nanda Kishore would be toasting the vote of thanks at the end, and Dr. Rajan Shukla would be moderating the question and answer session immediately after the presentation is complete, Dr. Shah. So over to you, Dr. Shah, and we look forward to hearing from you.
Thank you very much, sir. I think you've been more than profuse. I don't know if I deserve this much of introduction, and thanks again for the opportunity. And I don't think so it is out of place when I say thanks for the opportunity, because like you said, I have been a bridge between our institutions, and also I've had the unique sort of, what should I say, privilege of being your student as well. For years, I think we've known each other for more than 30 years now, sir. Thanks very much again, and thanks to all our colleagues there at the Indian Institute of Public Health, Hyderabad, and the larger Public Health Foundation family. So what I thought I will do is, as I share my screen, I'll probably take you through something which is which I thought would be more in terms of looking at converting questions which you raise as either research questions into practical sort of projects. And I wish to share these experiences with you, because I personally think that the logical continuum of asking question is related to actually institutionalizing them or scaling up something which works in the longer interest of public health. And that's precisely what thing. for a moment, when I suggested this topic to Dr. Jairam, I thought that, I was chuckling and thinking that, with, with titles, it's probably sometimes you think that if you can't convince somebody with a title, you confuse them. So you will see a longer title, but the intention is not to confuse all of you all, but to, try and convince you with what I wish to do in the next 35, 40 minutes. So what I've tried to do is I've structured the presentation in terms of briefly actually jogging your memory or reinforcing the concept of implementation research. And when I say jogging your memory or reinforcing the concept, I got a fellowship from the Emory University just because of PHFI and just because of the opportunity provided by PHFI and especially Professor Reddy and Dr. Murthy in terms of really making sure that I get some insights into what implementation research is all about. I will take you through the other aspects related to implementation research in terms of really uh, the importance of asking the right question, because like I said, if you ask the right question, there is every chance that this question can be converted into a feasible and implementable project. Uh, very briefly on methods and frameworks and why it's important for me to talk about methods and frameworks, you will understand. And from the time I've been in the university, I will share with you some of the experiences, at least a couple of experiences or three, in terms of how we've been managing to convert the questions which we have asked as part and parcel of some research studies into implementable projects. And these implementable projects, whether you call it, as an intermediary towards scoping up and scaling up, extremely important when it comes to the connotation related to public health. And I'll be open to any questions and answers with your permission. I guess I don't have to reiterate the fact that, uh, majority of our countries and across the world, and especially acute and low and middle income countries, you find what is called as the mechanics of failure in terms of the burdening healthcare programs or the burgeoning healthcare programs, and probably the health system which is skeletal or which is not prepared in terms of taking up this burden. And this basically constitutes one of our biggest problems in terms of ensuring whether it's comprehensive care, whether it's equity, whether it is making sure that you reach people with care, etc. So I call this mechanics of failure. And that's because what we find is there is a distinct gap between what we know and what people want. So there's a gap between the knowledge and need or knowledge and wants in terms of really translating whatever we know in terms of practical utilities for people for whom we care. So I guess this is where what I think as implementation research, which acts as a bridge between the knowledge and need, comes across. And critically, it's very important for us to understand that unless until you bridge this gap through implementation research or implementation sciences, I don't think so you can reach the amount of scale or amount of scope which you would probably look at when you're actually practicing public health. And that's where I thought it would be very interesting for all of you all to actually look at how important it is to generate those research questions and take some of these research questions and convert them into practically implementable projects in terms of really looking at the logical continuum between the question and the initiative, which is very important when it comes to public health. I guess this is something which you can look at the sentence, or you can look at the words and the red font where I've highlighted them or underlined them. I think the key challenges broadly, and this is not a mutually inclusive or a mutually exclusive list, but just to tell you, how do we take proven interventions which we know and implement them in a real world scenario? That's a critical question which we need to ask. I'm very happy, I acknowledge the presence of people like Dr. Shailaja, etc. I've just, I have a classmate of mine, and along with Shailaja and Dr. Raman Rao, who is here, they've introduced what is called as the ABC, or active bleeding control when it comes to road traffic accidents, etc. And it's such a wonderful project in terms of initiative, in terms of really training lay people in terms of providing at least that emergency care, or the first golden hour, if you can call it, especially when it comes to injuries, etc. And it's possible for us to do it, and this is real life situation. And I just want to acknowledge the fact that I was reading about it very recently, and this is where I come from in terms of really telling you that how important it is to take proven interventions and implement them in the real world. That's one challenge which we face. The other challenge is, we all know that interventions do exist, but one size cannot fit all. Whether it is implementing the vaccine initiative, or whether it is implementing other initiatives, you have to understand that the context or the diverse settings and the health systems differ from place to place. And it's important for us to actually, if it has to succeed, if the initiative has to be converted into something which is institutionalized and sustainable, we have to make sure that it is implementable in diverse settings and across health systems. These are two critical challenges, not withholding the fact that there are other challenges as well. Like I said, critical for us also is to consider contextual factors and understand that what can be achieved in theory, it's not what's written in your textbooks, and what's actually asked in the exam, or what you practice, are two different things. I think the same argument holds good when you look at understanding the difference between or the interface between what is achieved in theory and what actually happens in practice. These are very important questions which we ask when we talk about implementation science or implementation research. I think the most critical aspect related to this particular slide, or this particular set of points which I've put through, is it's very important for us to understand that, one, the questions which you raise with respect to implementation research or implementation science is primary, is the most important thing. It's important for us, and that's why I said that the question is the VIP, or it's question is the king or queen, as you want to call it. Let me be gender neutral in terms of saying that it's very important for us to ask the right questions and understand real world reflects a very complex situation. So this research is also very complex, and do understand this is where I think there is a sort of clash between what all of us call as evidence and evidence and evidence and everything supported by evidence, versus being thinking quickly on your feet, or making changes or adapting yourself in terms of implementers towards continuous adaptation. And that is where sometimes you find that there is a clash between evidence and what doesn't constitute in the real sense evidence, because you're working in a real life situation. So I want you to remember that raising the important questions, making sure that understanding that it is a complex process, and third and most important thing, also making sure that you have to continuously adapt to the implementation aspects related to any particular initiatives which you would like to pursue. This is more of textbook knowledge, or what is published in terms of trying to say that implementation research or frameworks basically exist as 5 categories of theories, models, and frameworks, whether it is in terms of looking at the process, whether you're looking at determinants, whether you're looking at classical theories which exist, or the operational implementation theories, or also looking at evaluating. This is where things like health technology assessment, health economics, etc., even qualitative research, etc. But Nandu is here, who's an expert in terms of really understanding the reasons behind why there's increased number of farmer suicides and what are the determinants, etc. I'm not going to step on his toes, but just to tell you that it's very, very critical for us to also take this in terms of really looking at how you can sort of formalize something in terms of carrying out your own research. Apart from that fact, I think this is a stepwise process. When I say that, and as early as 31 years ago, Detsky did say that how do you translate something called as basic research into public health research or public health action? So going through these different steps of fundamental research, looking at efficacy, effectiveness, using your resources very judiciously in terms of efficiency, then making it available to people who need it in terms of equity, affordability, etc. And make it disseminating all those findings. That is also very, very, very critical when you're making the journey with respect to implementation sciences. So already I think I'm hinting at the fact that this aspect related to implementation research takes a very, very comprehensive view and looks at it very multidisciplinarily. And I won't be wrong when I say this is more in terms of generating evidence to making decisions, whether it is a clinical decision or whether it is a public health decision, going through the different stages and taking everybody's consideration. We were just talking to somebody very recently, and we were discussing about one very important device or innovation which PHFI actually produced, and this was the Swasthya Slate. It was a fantastic device, a tablet-based sort of a device. 233 tests, costs about 50,000 rupees, etc. In terms of the device, could give you results in a thing. But how did it perform in real life situation? Probably it performed well in a couple of states, probably did not perform well in thing. What happened to the device ultimately? It must be at the Mohalla clinics in Delhi, it must be in some places in Jammu and Kashmir, etc. But what about its universal adaptation or universally being available in at least those centers which have a people interface, like for instance, here the Me Seva centers or the Bangalore One centers, etc. So please look at it from that aspect in terms of saying that you don't complete the cycle by just the innovation part of it. The percolation or permeation of this innovation is as equally important as the innovation itself, and that's a very important aspect related to implementation science. And so it's important for us to find the gap between the current state and the state which is desired in terms of making sure that we bridge that particular gap by asking the right questions. The point again I want to tell you is the fact that this is like a cobweb. It's you don't know where it starts and don't know where it ends and who is involved in terms of actually making sure this happens. And hence, if you may call it, we say that we provide, we do in our university and especially in my school, we have people who do bench or lab based research. Then we have people who also participate in bedside or clinical related research and clinical related service delivery. But ultimately, we are the people who are supposed to take this to the brass tacks, if you want to use the, the services terminology or the army terminology. So it's about translating bench, bedside, and brass tacks sort of an approach to ultimately benefit public health at large. So this is something which I thought is very important as a prelude towards what I would present now in terms of how we have made that journey between raising the questions and trying to put together as possible projects. So what I'll, and I again want to acknowledge the fact that Professor K.M. Venkat Narayan, who's at the Emory University and is an eminent diabetologist, more than a diabetologist, a fantastic epidemiologist and a public health person, who always said it's about, translating available knowledge into things which we can use every day. It's also making sure that, you look at standards of care, understand barriers, look at all the things which are very, very critical for us when it comes to healthcare delivery, as well as, improving quality of life and quality of care. So it's important for us, and I, as early as 2004, is what Venkat did talk about. And incidentally, he served as chair professor in our university because I asked him, sir, will you come? And he said, fine, I'll come and spend time with you all, and I'll take you through some of the things which is important when it comes to setting up a fledgling department. And that's where we benefited immensely from his tutelage or mentorship. So going to my experience sharing, let me share with you a couple of experience. And first and foremost, I want to take you through a sort of question which we asked. And this question pretty recent when I say when it comes to us, because this UNICEF and the state of government of Telangana asked us to really look at it as somebody external in terms of saying, why is there a increased cesarean section rates in the state? As a matter of fact, if you go to districts like the old Karimnagar district, which has now been divided into Jagtial, Pedapalli, Karimnagar, and all those kind of things. If you really look at it, the cesarean section rates, even in the public sector, is as high as 60%, whereas in the private hospital, it's about 80%. It looks like the cesarean sections are the natural thing to happen when it comes to deliveries. That's second nature. So this is a question we wanted to answer by actually getting the perspectives of not only those people who are doing the sections, but also those people who are beneficiaries or who have had cesarean or who have been subjected to the normal labor process. So what we actually did was, we like I said, it's pretty high, and as a matter of fact, even the last reported figures from NFHS talks about it going up from 58 to 60% in the state of Telangana. So the point is, we had, basically at the back of our mind, actually wanted to develop a framework to help the state in terms of looking at how will they address high cesarean section rates. That was something which we had at the back of our mind. But specifically, we wanted to answer that question as, why is there increased C-section rates? And so we carried out, some sort of a mixed methods, sort of a study where, like I said, epidemiologists and people who are quantitatively trained want to look at everything from the point of view of counts, numbers, etc. So it's like scratching the surface. But the deep research is basically what people like Nand Kishore and others do in terms of the qualitative research. So we wanted to do a combination of both to find out, why is there increased cesarean section rates in some districts compared to the other districts? And for that, we actually did very deep interviews. When I say deep, really deep, in-depth interviews, focus group discussions, a lot of stakeholder engagement for primary data collection with both observation and records linkages, which was available readily to us across the state. And as you can see, the distribution of where we did it is pretty much across all the 10 old districts of Telangana, including the newer ones. So this is what we did, and we looked at districts which had high rates, districts which were comparable rates, when I say relatively in the middle, and districts which had very low, to understand the reasons why is there a difference in a state with respect to cesarean sections. And interestingly, what we came up with based on data, thematic analysis, and all those kind of things, we found the determinants range from personal or family determinants. Like for the instance, earlier when we talked to the grandmother or mother-in-law, the mother of the lady who had delivered, who had a section, there was conflicting sort of opinion saying that, look, these days, they have only a couple of children at the most, so they have to have safe deliveries. We don't mind if we have cesarean section, which is the safest thing to do, and I can't see my daughter or daughter-in-law having pains and writhing with pains, etc. So the aspects related to smaller family size, late offspring, safety of the mother and child, early rehabilitation, etc. When it came to their own self, they said we used to deliver in the morning and we used to go to the field in the afternoon. So that's the sort of contrast which we got. That was one. Community determinants, you won't believe. We had, sort of a lot of people saying that, look, I think cesareans are just like episiotomies or, normal deliveries, because it's so common in our community that everybody has it and everybody seems to have recovered very well and started going back to whatever they were doing earlier. They were healthy, etc. So it's second nature for them. System determinants, and this is where, initiatives like, for instance, staff shortages, not having somebody to do normal deliveries, or do not have the patience, in fact, to do normal deliveries, etc., were very important as well. So also the fact that one of the things which came out, which led us to actually, formalizing this particular project was there was no support when it comes to providers, both for litigation as well as medical legal issues. And they were left on their own to fend. And sometimes they had political pressure. I've seen with my own eyes ministers' letters saying that here is my patient. She will develop labor pains. When she develop labor pains, please get her operated and you do it yourself. Those kind of letters people have preserved and showed it to me, saying that you had so much of pressure in terms of either an elective section or a lot of about the date, time, muhurtam and all those kind of things, which play a very important role, whether it's a leap year or whether like Dr. Murthy's birthday on 1st of January, etc. People would like to get their surgeries done on those days. Same thing with policy determinants, which was very important. When I say policy determinants, it's very interesting when you look at the sort of standard operating protocol or procedure with respect to guidelines with respect to antenatal visits. Even if you can deliver your second child in a PHC, for the third and fourth antenatal examination, you have to come to a facility which has ultrasound, which has surgical facilities, etc. So you are forcing people also as part and parcel of your own policy or guidelines into a system. And what happens is sometimes these people get lost to a public system and go end up in a private system and get operated, etc. What I'm trying to tell you is, if it's something which is normal, nothing requires an ultrasound or nothing requires advanced referral, etc., might as well deliver it at home or at the PHC near your place. So there are policy determinants. And one of the other things is people are not confident to do what is called as VBAC, vaginal birth after cesareans. And previous cesarean was the biggest indication for a repeat cesarean. So we found quite a lot of interesting things with this. And also we found certain barriers to cesarean sections also, whether it was personal family determinants, some families saying that, look, nothing like having a normal delivery, experiences of what I have gone through, etc., counseling them. You need to have a second pregnancy. If you have a first pregnancy delivered through section, you'll end up with a section, those kind of things. System determinants, like for instance, availability of facility, labor room, good facility, an A&M, or more recently midwives, etc., being available there, etc. And also facts like, when we went to places like Vanaparthi, Mehboob Nagar, etc., the distance between a facility which can do a cesarean versus a facility which can do a normal delivery is quite large. So it's pretty distant. So you probably would rather deliver with a lot of pain at a primary health center or wait for normal delivery, the process, whereas you don't have the ambulance facility or access facility. There are flip sides to all of these kind of things. So what we thought was, if this is the case, it's very important for us to look at one of these questions and turn them into a very operational sort of a project which could be implementable. So we wanted to actually look at one issue, and like I said, we looked at the issue of providing a supportive environment both at the community and institutional level, so as to prevent violence and medical legal issues. Related to which, we were very happy. It wouldn't have happened without the support of all the people. And when I say implementation research, please do understand, it's a very, very collaborative effort. It's more participatory. It's more sort of collaborative in terms of how you engage communities, how you engage people, etc., press, everybody, which is very important. So what actually happened was last year, we actually had this big Gates Challenge, sort of award or challenges which were announced with respect to improving access to safe and appropriate use of cesarean sections. So when we looked at it, we thought, why don't we actually, convert one of our questions and apply it as a project here. Incidentally, for us, we were very, very fortunate that University of Central Lancashire had one of the professors, Professor Sue Down, who happened to be the OBE. She was knighted by the Queen for a work with respect to midwifery. Please understand, she is not an obstetrician, she is not a medical doctor, she's a trained midwife nurse. So she actually was helping Fernandez Foundation here, setting up their midwifery program along with the government of Telangana, which had announced 120 posts of midwives across the state. So in that connection, we got in touch with her through the university, and we were very fortunate that we were awarded this particular project called Rejudge. Rejudge basically looks at developing something like a communication package for whom it's an open source multimedia evidence or behavioral change practice for whom? For lawyers and judges who decide obstetric litigations. And that's precisely what we were successful in. Just to tell you, this is a collaborative project between University of Central Lancashire being the principal investigator, World Health Organization, University of Dalhousie, ourselves, Brazil, etc., in terms of really looking at how do we reduce non-medically indicated cesarean section, and how do we achieve it through actually making available a multimedia evidence and behavioral change program meant for lawyers and judges. And it seemed like the title as well as the initiative impressed the people who were reviewing a proposal, and we got it. So what are we trying to do is, we are trying to look at it in terms of not being considered as defensive practice or defensive medicine, which is important for us also to look at it. So we are trying to look at how can health providers deliver cesarean section in terms of looking at it more of a human rights benefit to mother and baby issue, rather than protecting themselves from obstetric litigation or in terms of really personal protection or being defensive. So in that connection, we thought it was important to orient, and we think it is very novel in terms of making sure that because as you know, judges and lawyers probably deal with cases or make judgments based on precedents, past sort of experience, or sometimes personal experience itself. And most of this personal experience probably clouds the whole process of not being unbiased. So they become biased towards certain intervention, and probably that reflects in their judgment. I'm not hazarding a guess that that is what it happens, but I'm just trying to tell you that it was very important for us to be novel as well. So this involves, the project now is in the sort of initial stages. February of 2021 is when we got it. What we have done is we have looked at desk-based research in terms of scoping reviews. We are looking to do the formative work. So we are preparing for formative work, then develop that toolkit by consensus for the lawyers and judges, test it, then finalize it, and probably use community of practice. And when I say community of practice, very important to have this collaboration or co-development with respect to the people, all the stakeholders who are concerned, in terms of really making sure that this is ultimately used and there in the open access. So this happened to be one question converted into a project, which is now in the process of implementation. And as we move forward, probably we will get to know how important or how good we have been with respect to this. The next experience is something which is a contrast to what we did previously. Again, in terms of really looking at purely field-based towards converting something which is basic research or a device into scaling it up or scoping it in terms of what we think. So this is in terms of really looking at a nanotechnology or a microneedle patch. You can a microneedle patch developed using nanoneedles or nanotechnology supplement critical micronutrients for prevention and control of anemia? This incidentally, we have Dr. Reddy's Institute of Life Sciences within our campus. And along with us, the School of Medical Sciences, we have this collaboration, and which basically looking at anemia closely, then looking at developing a sort of sort of initiative in terms of a patch, which is microneedle in nature, which is transdermal, which can be applied for a week and you can forget it. And this for a week will release the micronutrients, which is iron and B12, to the body, as not only it can't substitute the recommended dietary allowance, but it can supplement or complement diet, and it can complement other things, etc. We thought this was important because the conventional therapy, whether it is oral or IV, and Dr. Murthy knows, I was also a medical officer in a primary health center in Haryana. And we used to, at that time, capsules were not available of iron and folic acid. And we used to give, sugar coated, red colored tablets, and we used to give them in newspaper. And when you hold the newspaper, when it is, summer, your sweat will actually dissolve the iron and folic acid coating of that red color. And these iron and folic acid actually will appear like goat droppings. People have told us that this looks like goat droppings. And, people would throw it at our doorstep or at a gate and go, or they may actually take it and give it to their buffaloes, because the buffaloes would give them milk. And that was the earning member in the family, not the male member. So they would say, ताकत चाहिए भैंस को, तो हम उसको खिला देंगे. So when we used to ask them for compliance, they used to say, yes, आपने गोली लिया? हाँ, गोली लिया. गोली खाया? इसे नहीं खिलाया. किसको खिलाया? भैंस को खिलाया. So the point I'm trying to make is, there were issues with respect to, or there are continuing to be issues with respect to compliance rate, whether it is stomach upsets, constipation, etc. Low biological availability, which is very, very critical. Almost all of us have a lot of deficiency, whether it is zinc or vitamin A, etc., even at adult ages. So it probably also makes sure that you have low biological bioavailability, side effects, fear of injections, pilferages, malpractice. So these are some of the things which we thought we will put forth when we put together this proposal. What we were supposed to do as public health people was, this is something which I want you all to actually remember. Most of the technologies, most of the devices, most of the things which you develop doesn't take into consideration the end user perception or the end user experience. It's very, very important. Just because you developed a device, it doesn't mean it's going to be accepted by everybody the way you want to accept it. So related to which, we thought we will also look at acceptance and utilization in terms of this microneedle patch. And we, this is the biological part, which I don't want to go into detail. But just to tell you, the novelty happens to be, there is no nutrient containing microneedle. You may get a nicotine patch, but you don't have a patch which delivers these important micronutrients. There are few iron containing patches for daily application, but not sustained release. So like I said, DBT was very interested. Government of India, Ministry of Science and Technology, they allocated this project last year, happened during the time when the COVID pandemic came. The product is almost developed. It's also sent for patenting. We are in the process of undertaking the acceptance and utilization surveys, etc. Patent also, like I said, has been thing. So what I'm trying to tell you is, here is another initiative where can we address something like micronutrient deficiency, especially looking at anemia in our population, especially when you look at mothers and when you look at children, through a sustainable use in terms of really making it commercially available, bringing down the cost, one-time application, no compliance issues, etc., etc. And it looks like it is happening with respect to what it is. Very quickly, in the next 5 minutes, I will go through a couple of more experiences, and very fortunate that I have a very dear colleague, Dr. Ranga Reddy, with us, with whom we have a very strong association, a memorandum where the Infection Control Academy of India, through which we looked at something which was lacking in our training or in our education. So in order to make sure that we arrive at something concrete and to kickstart our memorandum of understanding, we initially actually offered an online program, which was more in terms of primer for infection prevention and control. This was through the Commonwealth of Learning and SEMCA with the Infection Control Academy of India. I should say the university had very little role and does continue to have not a great role when it comes to doing everything. ICFI is basically what does everything. Uh, Over a period of time, we institutionalized this primer course into a 1-year postgraduate diploma in infection prevention and control through the Center for Distance and Virtual Learning. For those of you who are looking at the photograph on the left side, we were very fortunate that the Nightingale of India, Sarojini Naidu, actually bequeathed her house or gave it as a sort of gift to the university, and the university runs its apart from the fact that it's a heritage building, also has the Center for Virtual and Distance Learning there, through which we ran this particular program. And as all of you know, with a lot of emphasis on things like accreditation, NABL, NABH, and those kind of things, and infection prevention control or antimicrobial resistance and infection, healthcare associated infection, probably the second most important cause, public health in terms of deaths, etc. So we went ahead and did it. We offered a full-time diploma program. It's going on well. First batch has been completed, basically trying to help people with best practices of applying their healthcare associated or control and prevention of healthcare associated infections in their own settings with these objectives, etc. I just wanted to tell you that we launched the primer course, then looked at curriculums and things across the country, and Dr. Rangareddy and others have alluded to the fact that probably this is the first course anywhere in this part of the world, whether it is Southeast Asia or Western Pacific. We don't have such program. Western Pacific, probably Australia has, but the majority of Africa, Middle East, and Asia doesn't have such a program. And since we are offering it as a distance program, we had good response. First time 44 attendants, 26 graduated already. 54 got admitted for the second course. We had to call it a diploma course because the postgraduate diploma means something, and the UGC especially looked at it and said that any 1-year program will henceforth be called as a diploma program, and also banking of the credits and new education policy and all those kind of things. We have a lot of students from the Gulf countries, Qatar, United Arab Emirates, Saudi Arabia, etc. And we also think that we'll get more and more students from other parts of the world. Next is for us to really look at kickstarting the antimicrobial resistance related program, and ultimately setting up something like a virtual center for One Health. This is another thing which we are trying to do, and we will have collaborations with all concerned here, and we will seek the guidance of people like Dr. Murthy and Dr. Jairam, etc., and colleagues in order to make sure. Just to conclude very quickly, we are also looking at things like quality of life and utility measures associated with childhood visual impairment. The DALIs probably are applicable to adults, but when it comes to tailor-made populations, or when it looked at customized things like children, we probably are falling short. And one of my PhD scholar, who's also a public health professional, is working on this in terms of developing the utility measures. We have done pretty well with respect to coming to a stage where we can start looking at those utility measures and testing them out. We have questions ready for the Department of Tribal Welfare, Telangana State. And here, Professor Sharma, who's also a teacher to Dr. Nandu, and an anthropologist and teaches medical anthropology, etc., and us collaborated. We have come up with the particularly vulnerable tribal groups in terms of really looking at their health problems, things like status of health and illness behavior, looking at home-based neonatal care, because a lot of these people don't come to institutions or seek neonatal intensive care units. Questions are ready. Now we have to look forward to instituting them as projects. Very quickly, I think I don't have to, reiterate the fact that implementation science and research like this, when you're going to do our projects or institutionalizing, sustaining those kind of things, when you're going to do, has to be participatory, interdisciplinary in nature. Very happy that within the university there are 12 schools And if I want, I can, and 12 schools and close to 30 centers. If I want to associate myself with any of the schools, I'm very happy, whether it is social sciences, humanities, whether it is management, etc., engineering sciences, etc. We have that opportunity in order to make sure that we complete this plan, do, study, and act sort of a cycle. What I'm trying to tell you is an enabling environment, a facilitating environment, even with the public sector, even within the public sector is equally important. Somebody who's guided me through this process is Dr. Murthy, like the way he, set up things within the RP Center, All India Institute. So I probably will end by saying that diffusion, dissemination, implementation continuum is very, very important. But please do please do remember, it's not about converting the projects into converting the questions into projects, but making sure they're sustained. Then making sure that you're institutionalizing them. I may be here, I may not be here, but probably the things which we have set up, if it becomes part and parcel of a larger social sort of accountability, responsibility policy, then it becomes very important. Implementation science, I just want to be a little skeptical here, has suffered because first and foremost, all of us here, I think we have to understand that fact there is a lack of understanding. It may not be applicable to PHFI, the Indian Institute of Public Health, but across the board, people lack, even those people who are supposed to be teaching sometimes lack this understanding with respect to things. Of course, there's a lack of investment. It's very important that health innovations, we spend a lot, we develop a lot of technology. You see it during the COVID times. COVID Home is something which IIT Hyderabad has developed, etc. And but how best we use them, or how best we make sure that it reaches people who need them at a cost which they can afford, or at something which can ensure equity, is something which we need to see. Thank you very much. I'll stop here and I'll be open to questions. Thank you, sir.
Thank you, Dr. Shyam. Always fascinating to listen to you, and always fascinating when you end with Bhutan, because it reminds me of the years that I spent there in the early part of my career. Yeah, I think you made some very critical points, but the most important of that entire thing, whether you call it implementation research or translation research, or by any other name, the most critical thing that we have to keep in mind is how do we ensure acceptance and sustainability. And both these aspects are very critical, like in your nanotechnology study on iron and B12 supplementation, you're looking at acceptance. How does the community accept this? That is very critical, because without that, there would not be sustainability. So an idea can't be built, in the clouds. It can be conceived in the clouds, but unless it comes down to the ground and germinates the soil, it will not take root. So that is very, very important, that we have to look at going towards that angle of sustainability. And whatever money we put in, you have to look at how many years down the line will I look at getting a return which is consistent. You all, Dr. Shamanna and a couple of the others in this call would remember our colleague, late Dr. Bir Singh, who was with us at AIIMS. So, Maggi had just come into the market in 1984, and Dr. Bir Singh's eldest son, who's himself a doctor now, would not eat anything else except in Maggi noodles. And everybody was thinking as those days, I'm talking about 84, how can a product which is not a dosa, idli, chole bhature mix ever succeed in India? Today in 2021, even Baba Ramdev wants to fight with them and enter the noodles market. So that is how sustainability has to be looked at. That can this idea really succeed even if it's an alien environment, if the idea can succeed, then that is something one must go for. So thank you, Dr. Cham. This was an excellent presentation. And there were some questions, and I'm sure Dr. Rajan would coordinate and moderate the session. And I can see one question, Dr. Rajan. I hope you're able to.
Yes, sir.
Yeah, please, it's over to you.
So there was a question earlier on when you were, Professor Shamanna, when you were talking about the Rejudge project. And the question was from Khushbu. Can you brief more on the behavioral change which was done for the C-section Rejudge project?
Thanks very much, Rajan, and thanks very much for a very interesting question, Khushbu. At this point in time, what we try to do with respect to understanding the determinants is more in terms of really looking at looking also at the behavioral aspect related to why people opt for one or two. We hope now that the project itself, we will take into consideration the behavioral communication aspects related to changing the behavior of those people who are going to make these judgments. But I can tell you with respect to the other thing, development of this nanotechnology patch, before as the nanotechnology patch was being developed by Dr. Reddy's Institute, with respect to patch, I sent out my students, and especially a couple of my MPH students, I said, go and ask people, show them this prototype of a patch and ask them if they would wear it. Very interestingly, Khushbu, you should understand, they said that the point is we will use the patch provided it is not visible. You put it in a place where it is concealed. That was one of the response which we came from predominantly rural women. They said, look, we are dark skinned people, right? And if the patch is of some other color, it looks very odd. And if you put it in a place which is exposed. So one thing which we got to know was, even if you develop the patch, application of the patch should be in a place where it is not visible in terms of it. That's an aspect related to, psychology, behavior, etc. The next thing they said was, can you make the patch similar to the color of our skin? Can you customize it in such way that it is transparent in nature, that it doesn't show up as something which is very, very different? These are some of the things which we already had some sort of inkling, and this is fed into the development itself, which very rarely happens. And I think I've tried to tell you some aspect related to behavior. We have not gone ahead. Karthik, my PhD scholar, will look at behavioral change when it comes to studying the determinants in more detail, especially with respect to cesarean sections. But with respect to other things, thanks for pointing that out, and it's a very important question. Thanks, Khushbu.
Yeah, thank you, Professor Shamanna. There is another question, in fact, a couple of questions from Dr. Suresh Kumar Kamlakan. He wants to know your opinion on including the implementation research and science curriculum in primarily health and medical courses in India, and what would be the potential strategies, especially within health system, to bridge the gap in evidence and implementation in actual practice.
Thanks very much, Suresh, and I hope you're well. It's something which I and you basically know in terms of saying that as we move towards more and more sort of case-based learning, problem-based learning, moving away from the rote aspects related or experiential learning, we will have opportunities to introduce these as a part and parcel of a curriculum. I took Academic Council's approval for running an elective course on implementation science, and very happy to tell you that the Academic Council approved it. We now can run an elective course. We can make it an open elective, and if it is going to continue on an online mode, I would welcome anybody to attend this thing. Probably we will not even make it, in terms of really, we will not make it commercial. We will make it sure. We'll make sure that it is available to all, at least to spread that message. Thanks very much.
I have a question of my own. I'm waiting for other questions to come, but while they come, So you did mention when you were talking about the Swast Slate, a very good innovation, but sort of did not take off to the level, uh, to its full potential. And the question is coming from there. There are two parts of the question. Part one is, uh, when you are innovating and developing something, you want to protect that innovation, and at the same time you need to take feedback from the end users and from the system players. Okay, how do you balance both, and what sort of I mean, because we have seen that a lot of innovation happens and it fails because the end users and the system application has not been there, and understanding has not been there. Basically people have not been involved.
Thanks, Rajan. I think you hit the nail on the head in terms of these days you see a lot of things being developed, and this is for public use and this is for public consumption. If I'm going to share my slides, I'm going to say you don't even have to acknowledge me because I have taken it from different sources. Use it. But with respect to issues related to intellectual property, patent laws, and those kind of things, which is still primitive when it comes to a lot of things which we develop. I think there is the trust deficit, if I should call it, in terms of making sure that this really you know, is widespread used, and it's something which can be scaled up, etc. So I think we are still our regulatory frameworks, etc., for a lot of things are still primitive, and we would like to do more on that, and wherever possible, getting the end user perspective in terms of developing the product, which doesn't happen. I've seen even programs of health technology assessment. I don't see anything related to the fact that you take into consideration the end user. And Shailendra, my PhD scholar, is basically looking at the end user perspective in the sense how do people, or like I see a question from Dr. Seema in terms of community engagement, drive this aspect related to implementation research. I think that should be a very important aspect if you want to make it sustainable and institutionalized.
Dr. T.V. Ramana Rao also has put up a question and is referring to in sudden cardiac arrest, the Utstein formula was conceived. And with reference to that, can such a framework of implementation be applied to public health in general?
So probably, I think we will look forward to Emery and people like you in terms of driving us towards making sure that this is sort of done, sir. I would personally think that, like for instance, IIPH Hyderabad and one of our colleague, Dr. Raghu, actually developed a lot of things with respect to making sure that what is the sort of information or prescription things which you can do to deal with blood pressure management or diabetes management, etc., decision making tools at a primary health center level. Probably you can drill it down to ANMs and other people, etc., and over a period of time I'm sure that this emergency care or the golden hour also can come into existence. At this point in time, sir, I will inform myself more on this Utstein formula. I will get back to you, sir.
Yeah. Thank you, Dr. Ramana Rao, for raising that question. Very important. And we do need, for anything to take up, we do need to have frameworks implemented, and we need to look forward to developing a framework for implementation research in India. And I think the next question is also related to that only. Does linking research and innovation to public health policy increase the entrepreneurship?
Oh yes, very much so. I guess. Don't you think we have a head start in our country with respect to the whole startup sort of an environment and the tinkering labs and the innovation centers, etc. I think that's why I said the innovation part is taken care of, but what about making sure that the innovation ultimately benefits the people at large? How do you make sure that the people use it? I remember Professor Dr. Kalam, when he was president, came up with this initiative called Pura. Pura stood for, as the name implies, city or town. Pura also stood for providing urban amenities in rural areas. And that was, Pura was his brainchild. He said, why don't we make sure that our villages and, interior areas also get the same sort of amenities which people get in towns. But it was the people who actually told him. It was also the same with the interlinking of rivers, etc. People who told him, look, sir, the point is the environment will get destroyed. There'll be issues with this. They had their own, same concerns. So I completely agree with the anonymous attendee who raised this question, where he said, or she said, it's important for innovation as well as linking it up to public health and public policy. And it's happening. Just to give you an example, visual inspection of cervix with acetic acid versus pap smear. We have this device, and this technology has been sort of universally sort of sent to all the places within the country. But what has happened to it? Did you provide the sort of supportive environment? Now, can you do it at a community level? Can you inspect cervix at a community level? No, you can't do it. It gets stayed at a central level, and there you can ensure privacy. They can ensure people who can use it and all those kind of things. So it was a good innovation. It was probably saved a lot of costs and time and all those kind of things. But with respect to making sure that it took into consideration the end user perspective, it failed.
Yeah, it would have virtually revolutionized the cervical cancer field.
Absolutely, absolutely.
So I don't think there are more questions. I think one more question has just come in. Can you elaborate how qualitative data was analyzed for the implementation? Which project was it? The Rejudge project or the other project? That the questioner has not asked. So
I'll direct this question to the person who will give the vote of thanks, to Nandu.
No, I think it is about your cesarean section.
Okay,
sir, like I said,
Rejudge project. Okay.
Yeah, as a precursor to Rejudge, I think we did. I told you that some of the methods used were in-depth interviews, focus group discussions, participant observation. The same standard analysis which you basically do for qualitative research. I'm not escaping answering your question because I know little about qualitative data analysis. Let me be very frank. Whether it is free listing, grouping, devising the codes, putting together the themes, etc. That was what was basically done. Nandu, help me out, boss.
Happy to be part of the project and help you out, sir.
Yes.
And I think exactly you got it all right. Having the data collected and then having a thematic framework to analyze it. One way of analyzing qualitative data in public health research. That's a good way to do it.
Yeah, I think.
I think, Dr. Rajan, if there are no more questions, then we could ask Dr. Nandu to carry on with toasting Dr. Shyam. That's what I was about to say.
Yes,
Nandu, you can raise the toast for Dr. Shyam.
Wish Dr. Shyam gives us opportunities like this more frequently. So, formal vote of thanks. Good evening, everyone. It's my pleasure to present a vote of thanks for today's webinar on behalf of Indian Institute of Public Health. I would like to thank our guest webinar speaker, Professor Shamana, who's also a former colleague and also good friend of IAPH and all of us for that matter, for sharing us with his vast experiences and interesting perspectives on implementing the topic implementation of projects and the continuum to the logical continuum after that. So we have enjoyed listening to your public health journey. Very exciting and inspiring. Very diverse questions you raised and very pertinent question. Also well planned and executed translation of research into practice. We wish you all the best with the projects which are ready to go into the operational phase for translation. And I should say kudos to you and your team, sir. And translating research questions into public health programs is, I think, is a very immensely complex challenge what we are facing as a public health discipline. And it, as you rightly pointed out, it's interdisciplinary, participatory, and more than anything, collaboratory. And it is certainly this implementation research is indeed the need of hour to address both our existing, public health challenges and emerging public health challenges such as COVID and other challenges, public health challenges. Thank you, sir, for being with us in spite of your busy schedule. It was enriching talk for all of us, and I'm sure it was inspiring for all of our MPH students who were there in the session today. I'd like to thank our director, Professor Murthy sir, for setting a stage for the webinar series and also for providing very incisive comments across this series and lectures being delivered as a part of this series. And Jairam sir was always there facilitating this webinar, and Chaitanya for facilitating the technology part of it. But finally, thank you all the participants from the PHFI, IIPH families across, students and others who were there for the webinar today. Thank you so much for all being there and actively participating with your questions. And we look forward to your participation in the further webinars that will be organized on this platform. Thank you, everyone.
Thank you so much, Dr. Nandu, Dr. Shah, Dr. Jairam, and Dr. Raj. Thank you very much.
Thank you.
Thank you, Shyam sir.
Thank you, Jairam sir. With your permission, can I exit?
Yes, sir.